Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. This episode features content from an educational presentation titled Optimizing HIV Outcomes in Challenging Scenarios. This is part of the comprehensive program, Contemporary HIV Treatment and Prevention 2022. During this episode, Dr. Timothy Wilkin from Weill Cornell Medicine in New York provides a case-based overview of switching antiretroviral therapy in a patient with viral suppression on their current regimen, but who also has a history of previous virologic failure with drug resistance mutations. For more information about Dr. Wilkin and this program, and to follow along with the slides, please visit the link in the show notes. So now let's turn it over to Dr. Wilkin, who will begin by introducing the patient case scenario.
So this is a 70-year-old diagnosed with HIV in 2009 when she was presented with pneumocystis, low CD4 counts. She did well on efavirenz, FTC, TDF. However, she's had some trouble with intermittent adherence that's led to viral rebound. Resistance testing now shows K103N and M184V. So K103N confirming resistance to the efavirenz and M184V to emtricitabine. So in 2013, she was switched to atazanavir plus raltegravir plus FTC TDF, and then later was switched to darunavir, cobicistat, dolutegravir, FTC TDF. However, she continued to have diarrhea. So currently her HIV viral load is undetectable, her CD4 count's 160. She now requires rosuvastatin for cardiovascular disease. She'd like a simpler regimen that doesn't cause GI issues and that will increase her CD4 count. So when we think about switching people who are virologically suppressed, it's important to review their history for prior virologic failure. We want to understand all their resistance tests. And if we're not quite sure about all the resistance testing, we'd only want to switch the regimen if the new regimen is likely to maintain suppression. Usually within-class switches are okay if there's no prior resistance, but we want to consult an expert of switching if there was more extensive resistance or resistance to more than one class. We have to review their ART history for intolerance. Remember, if we're considering abacavir, which we don't use as commonly today, that person would need to get HLA-B5701 testing. We also need to look at drug-drug interactions with any medication switches. Comorbidities, hepatitis B is a critical one. We have a lot of regimens now that don't require NRTIs. And consequently, they don't have any protect or don't treat hepatitis B. So we need to know whether the person has chronic hepatitis B before we stop or change their NRTIs. We also look at cardiovascular risk, renal function, bone mineral density, pregnancy considerations if they're interested in becoming pregnant. All of this is important when we think about changing medications around. So this was a study that looked at switching a drug with a high barrier of resistance, lopinavir, ritonavir, to a drug with a relatively low barrier of resistance, raltegravir. So it's important to know that everybody was sensitive to raltegravir in this study that entered the study. However, we know lopinavir, ritonavir, it's very difficult to develop resistance to that, and whereas it can happen more commonly with raltegravir. So what we found was that people who switched to raltegravir, the lower genetic barrier of resistance, develop resistance more commonly. So really not thought to be a good strategy. So some other switch studies that we have, people have switched from dolutegravir to bictegravir with viral suppression, and whether or not many of these people did have some prior NRTI resistance. And really, there didn't seem to be any difference in outcomes. So you could switch from dolutegravir to bictegravir. So what's important to note that both of these drugs have a high barrier resistance. It's hard to develop resistance to these drugs. So suggesting that's a safe switch. And so the good outcomes we're seeing, regardless of whether somebody had NRTI resistance in the past or not, all the groups seem to do quite well with this switch. When we talk about poor CD4 cell count recovery, it is a concern for patients. It does seem that their lower CD4 counts probably do put them at higher risk for certain long-term conditions. However, we really don't have any specific interventions for this. we don't have a way of treating the poor CD4 cell count recovery. So adding or switching ARB drugs is not recommended. There have been some small studies, but nothing has really shown promise for affecting immune cell recovery. There were large studies conducted of interleukin-2. So interleukin-2 does increase CD4 cell count. So the lab report you get, your CD4 count will go up on IL-2. However, it did not lead to better outcomes. So people were just as likely to develop these kind of severe complications from AIDS or non-AIDS causes when taking IL-2. Although it raises CD4 count, it doesn't seem to lead to any discernible benefit to the patient, and in some cases harm. So it's not a recommended strategy. So the best approach is to avoid low CD4 counts in the first place, which is done through early diagnosis and early initiation of ART. However, we don't really have a strategy for how to deal with low CD4 cell counts for people who are already on HIV therapy. So what we do is focus on managing modifiable causes or risk factors for immune suppression and chronic diseases, which is basically optimal medical management. However, this, we really don't know how much this will improve the CD4 cell count. She switched to dolutegravir FTC TAF with stable suppression and resolution of diarrhea, which is terrific. And then from dolutegravir FTC TAF, she switched to bictegravir FTC TAF to simplify to 1 pill once a day. So no etiology was identified to explain her poor CD4 cell count response. And so there was the effort to work on her modifications for chronic diseases.
Thank you, Dr. Wilkin, for sharing your insights with us. And thank you for listening. Look out for more episodes in this series at clinicaloptions.com/HIV.